All right, I have to pick up the pace a little bit. I'm actually not talking fast enough, apparently. So let's go on, talk about, keep finishing up on propofol, and we'll talk about etomidate next. Propofol's effects on the central nervous system is positive in certain respects, but negative in others. It does decrease the cerebral metabolic rate of oxygen consumption, which is what you'd want. It decreases the ICP, and it decreases cerebral blood flow. But really the big problem is that large doses of it can cause hypotension, especially patients that are in post-traumatic injury, and can lead to an overall drop in cerebral perfusion pressure, which is detrimental. So as long as you maintain adequate cerebral perfusion pressure, then you're okay with this drug, but it can induce some problems for you. The other thing that propofol does is very similar in EEG changes as thiopental. It decreases burst suppression. It can actually cause problems if you're trying to monitor things like somatosensory evoked potentials or motor evoked potentials. They're both decreased. Propofol's cardiovascular effects is like all the barbiturates and benzodiazepines. They're all preload reducers. This drug also is the same. It's a preload reducer. It actually has a greater reduction doses when you give equivalent doses in thiopental. Airflow is mildly decreased. Contractility is actually suppressed and becomes really a problem in people with low contractility states. So you've got to be a little bit more careful with people with low contractility states with Diprovan. My point would be just give less and go a little bit more careful. And the people seem to do fine. When you hit them with a big bolus, that's when you get in trouble with it. The heart rate should initially increase, that you expect. It's a vagal brainstem effect, followed by bradycardia, because of suppression of the spinal cardiac accelerator fibers, which is what you tend to see written all over the textbooks. Fall in blood pressure is often accompanied by changes in cardiac output and SVR, and hypotension can be very greatly exaggerated in patients that are hypotensive. Okay, so be very careful with patients that are hypovolemic, because you're preload sensitive at that point. So patients that are traumatically injured are more sensitive. Elderly patients are a little more sensitive because they have less fluid volume in them. And if you have compromised LV function, it may also exaggerate the hypotensive effect on induction. When you do intubation, it actually reverses the hypotension. We call it the metal-ephedrine effect. It's like when you put the blade in, it acts like 10 milligrams of ephedrine. So it does reverse the effects. Okay? And you'll hear us tell you that. It says, time to give the metal-ephedrine, which means it's time to intubate to reverse the hypotension. Okay? Propofol and electrical cardiac effects. Bradycardia can be very profound if you give enough of a dose, but it doesn't appear to alter the SA or AV node function. And it is not apparently bad if you have somebody with WPW. And actually, there's one case where they were actually doing an EP study, and they actually gave the person Diprovan for maintenance, and the delta waves went away. So it definitely does not affect the AV node, but it may actually bind onto the accessory sites and shut them out, which is maybe not something you want to do when you're doing an electrophysiologic study where you're trying to ablate it. But most of the time, when you give Diprovan at low doses, it doesn't seem to have that effect. And it has no prolongation of the QT interval. So overall, the heart-wise, except for the bradycardia, it's okay. Now, there has been reported cases of bradycardic-related deaths. Propofol can induce a very profound bradycardia and asystole, and even despite the person giving anticholinergics like atropine to that individual, which is kind of scary. It's been estimated about 1 in 0.4 to 100,000. I've done a lot of anesthetics, and I've never seen this effect, so it makes me think that it could be something else that's going on. So I just think it's a little bit strange that, we do this all the time. We're not seeing that effect as much. It might have been that the formulation has changed since the time that it was first reported. You also have severe refractory and fatal bradycardia and children in the ICU with prolonged propofol use. That makes sense because you're actually causing microembolization from the high doses of lipid, which is lipemic plasma, and I think that's how that's affecting that. You begin to affect the blood flow going into the subendocardium and get the fatal arrhythmias that you get. You also, one of the things that you got to be careful with when you're doing propofol is if you're doing eye procedures, it increases the oculocardiac reflex. Well, you read that in the textbook and you go like, well, what is that, right? How many people know what an octocardiac reflex is? Well, guess what? They're going to ask you on your boards, in your certs. So I decided to add in the slide for you. Is this. This is the octocardiac reflex. Okay? Basically, when you pull on the eye or you compress on the eye, okay, you can actually cause the ciliary nerves to be activated. Okay? The ciliary nerves are connected to the trigeminal nerve, which is cranial nerve number 5, and it's on the ophthalmic branch. So the ophthalmic branch of the trigeminal nerve is where the afferent information is coming back. Okay? Once it comes back, it goes into the trigeminal nucleus that's inside the brainstem, and the trigeminal nucleus talks to the vagus nerve via what's called internuncial fibers. These internuncial fibers connect up to the vagus nerve, which is cranial nerve number 10, and activate it and cause a very profound bradycardia, even to the point of asystole. The good thing is this reverses with anticholinergics. So you give these people atropine, which is why every time you do eye surgery, you must have atropine readily available, because this will happen. And even with the block working properly, with the retrobulbar block working properly, you still can get this kind of effect. Okay? So this is what they ask you on your test. They ask you which is the afferent branch of the octocardiac reflex. The answer is the ophthalmic branch of the trigeminal nerve, which is cranial nerve number 5. Propofol's effects on intraocular pressure are positive in the sense that they decrease intraocular pressure after you have an IV induction. So it's a great kind of agent to use if somebody has an open globe injury. It decreases it to the point that it's a 20-30% decrease in intraocular pressure. If you're doing TIVA with propofol, it's great for, when you're doing laparoscopic procedures. When you put people with laparoscopic procedures, intraocular pressure will rise. And if you have somebody with glaucoma, it might be safer if you do that case with TIVA. It may not be the easiest way to do it, but it actually decreases the intraocular pressure, and some people are concerned that you can get some blindness, although it hasn't been reported with this, so I don't know. It's just another thing that worry about, and we worry a lot about different things. So. Propofol's effect on ventilation: if you give too much of it too fast, apnea will ensue. If you keep giving the dose, it'll creep into apnea. So you will expect a dose-dependent decrease in ventilation. So what happens? How does it affect ventilation? Well, it depresses your actual tidal volume by about 40%, and it also suppresses your breathing rate by 20%. So your overall minute ventilation drops considerably, almost to 60%. So the CO2 values rise. So you should expect, if you're somebody spontaneously breathing on TIVA, to have a CO2 in the 50s. That's normal. It's simply from the suppression of the central nervous system by the diaphragm. Okay? When you add opiates to it, you can add a much more prolonged apnea than you expect, and that's one of the dangers of adding the narcotics to it. Propofol's effects on the airways are good in the sense that you have decreases in airway reflexes, because that's when you're trying to intubate, so that's appropriate. But unfortunately, one of the things it does is it decreases the response to aspiration. So people can vomit on you while they're asleep, and they won't cause laryngospasm, they won't protect their airway, and they will aspirate. Okay? So you've got to make sure that when you're doing this, you've got a secure airway if you have a full stomach, so you want to make sure they're intubated. It's not appropriate to do an LMA on somebody who's not a protected stomach. You can also have bronchodilation, which is kind of nice, but the sulfites, if you add sulfite to it, you may actually get bronchospasm. The sulfur dioxide gas has been known to cause bronchospasm in some individuals. So as long as you don't have that into your propofol itself, it's a bronchodilator. And actually has been used to reverse partially somebody with asthma. I wouldn't consider it a really high drug on my end to reverse asthma attacks. I would use other things. HPV seems to be unchanged using the propofol, which is kind of nice. How about the liver and the kidneys? It's not toxic to them, so there's really no adverse effects to the liver or kidneys as long as it's short term. With prolonged infusions, you get micromissile accumulation, which may cause the damage. Then you get what's called hepatocellular damage from that. You get lactic acidosis, bradyarrhythmias, and rhabdomyolysis that develops. The rhabdo makes sense if you think about it as a microembolization that takes place. It goes into the skeletal muscle and it decreases the blood flow, so the blood flow doesn't get to the skeleton muscle and gets you into trouble, where you get into rhabdo and you get the lactic acid as a consequence. And I've never seen this. So the book says that it can form green urine due to the presence of phenol, but that's really got to be giving it to a long time to somebody. I've never seen it. So has anybody seen that? You have? Wow. How long were you infusing the Diprovan? Okay. Well, good. Well, guess what? Anesthesia doesn't give anybody 3 days of Diprovan. So, cool. So you give me minty fresh? Okay. Happy St. Patty's Day. We could all pee in the we call it Chicago River at the same time, huh? All right. Allergic reactions to things can occur with propofol. The phenol nucleus can cause problems, sometimes as well as the diisopropyl side chains, and may lead to anaphylaxis and bronchoconstriction in these allergic reactions. These are rare, thank goodness, and sometimes people make a little bit too much of it. The pharmaceutical companies wanted you to buy the sulfite-free stuff because they were charging you $20 more for the sulfite-free stuff, even though the sulfite stuff that they were using before was perfect until the new stuff came out and the other one went out of patent. So a lot of us just sort of got a little bit skeptical after that and go like, come on. What's unfortunately happened to anesthesia is that the interest level for anesthesia drugs has waned and almost gone to zero. It's almost gone into a null state right now, which is kind of scary because, well, I think we are pretty good now, but we could be a lot better if somebody was actually putting research money into it. But there's really not enough money going into it, and if they keep cutting back on all the costs of all the drugs, we're basically going to be stuck with these medications for the rest of our career, and we're not going to have any different medications, which is okay, I guess. Abuse potential is an issue. I've seen residents do propofol, not with good outcomes. One guy died. The other guy lost his career. So this is something, don't play with this stuff. It is addicting, and it is very, very dangerous. It's like giving yourself an anesthetic without anybody monitoring you. Not smart. You could be like Michael Jackson, who's a perfect example of what happens to you when you take this stuff without proper monitoring. Caution with what's called propofol infusion syndrome. It was described in 1992. It's for long dosages. Symptoms you get is bradycardia unresponsive to treatment with asystole. I think this is all due to microembolization personally. Okay? I think what ends up happening is after a prolonged period of time in the intensive care unit, these lipemic molecules become coalescing and they cause microembolization. And because they knock out little microcapillaries, they'll knock out the heart, they'll knock out things like muscle, where the blood flow is going in high amounts. So you get rhabdo, you get also fatty infiltration in the liver, and eventually, if you clog enough of the capillaries, you'll cause a rhabdo-like effect as well as a lactic acidosis because you're not perfusing that tissue anymore. So I think that's the main mechanism. If you see a person developing tachycardia that you can't really explain, you should draw blood gas and see if the person's developing lactic acidosis. And then the differential should be in your mind that, hey, maybe I should need to stop this Diprovan. The way I would also do is take the blood and shake it. And if you see little white droplets come out of the blood, that's lipemic, and you need to stop the Diprovan. You're giving way too much. Most of the time it's reversible as long as you discontinue it early. If you don't, eventually it ends up what's called poisoning the electron transport chain, and it impairs the oxidation of long fatty acid chains and causes death in the individual. Caution with propofol co-convulsant effects. I think this is really questionable. I've seen myoclonus. Myoclonus means a person becomes rigid. That doesn't mean they're seizing. Okay, you have to show me that in EEG for me to believe that. Okay, I've seen people get rigid from lots of different medications. Okay, especially with GABA-like agents that we're giving, GABA agonists. And when you do these EEGs, these people don't have any EEG changes. So that's inconsistent with seizure activity. So really, propofol does not really produce seizure activity. Most feel it's free to administer in patients with seizure history. The question is, if you have uncontrolled epilepsy, well, at that point, you're in a bad place. Even if you give the drug, who knows if it's stopping it or making it worse? You can't tell. So for that reason, it's better to use other agents to stop the seizure activity at that point. Bacterial growth is a real issue, so potential for bacterial contamination. We really recommend use aseptic technique. The way I do it is we've gone away from vials, but if you do have vials at the hospital where you're at, this is what gets you contaminated. You see where they put the thumb at? When they break it at that point, that's where the bacterial contamination takes place. You leave a little bacteria on the edge of the glass. And then if you put the needle in and it goes directly in the middle of the vial, you taps on the glass, now you contaminate the needle, and now it gets inside your propofol. So what I would recommend you do is you take an alcohol swab and wrap it around it, and then break the vial using the alcohol swab. First thing, two things it does. It protects your fingers from getting cut. The first time I've gotten cut with this and I made a big slash, I almost had to put 3 stitches in my hand. So I learned pretty quick this stuff is pretty nasty. So what I personally do to protect myself is I put the alcohol around it, then I took a little 4x4 sponge, and then break it. And that way the glass doesn't go all over the place, doesn't get in my eyes, doesn't get in my hands, and I'm happy. Okay? Immediately then you should take the material and put it into your syringe, doing it aseptically. And then if you have the medication sitting there more than 6 hours, you need to get rid of it. So it is not appropriate before you go to home to draw up propofol before you go home, because in case you might get called in. You're not in a trauma center. If you're going home, what the hell are you drawing up medications for? I don't get it. And people do that all the time. You know, when you come back in, just have, you can't even have the syringe ready now, but just come back in and draw it. It takes you 5 minutes to do this stuff. It's not that much of a time saver. Trust me. Okay, now if we were in a trauma center, you wouldn't be drawing up Diprovan anyways, okay, because it's not an appropriate thing to be using for a traumatically injured patient. So, again, don't draw the stuff up unless you need to, because you don't want to waste drugs. This stuff is not cheap, and if the shortages continue, we're going to be like a third world country where the only time you draw something is when you need to use it. Otherwise, there's so much waste in this country, in the operating rooms. You just cannot believe the degree of waste. The reason that we're not filling up stuff, just tons of medical material going out, is what's happened is they decided a few years ago that one of the New York hospitals, they were dumping all this medical waste, and then they were just taking and throwing it into the ocean. Well, then it washed up with needles on the beach. Most people didn't like that idea. Okay, so now what they're doing is that all hospitals pretty much have waste disposal units in their hospitals, and they burn everything. So we incinerate everything. We do the same thing here. So that sort of hides all the things, how much waste we have. And trust me, we used to have gowns that we used to clean and put it back. Now we have paper, so we're killing more trees. And it's just very expensive what we're doing. How long that will be able to last, I don't know. We'll see. We'll see who's got the biggest bucks in their pocket. As for propofol, it's also a painful injection site. It occurs in less than 10% of patients if you give it in a large vein. But most of the time we put it in the small veins of the hand, so that causes a problem. You can decrease the pain of injection by giving 1% lidocaine, which is at usually 0.1 milligrams per kilo. 1 milligrams per kilo to 1.5 milligrams per kilo. Don't go above that. Okay. And the proper way of doing it is put a little tourniquet up, inject the lidocaine, wait 30 seconds, take the tourniquet down, then inject the Diprovan, and the person won't hurt at all. The other thing that people use is you add fentanyl up front. The problem with that is if you have an older person, not a good idea. I don't use fentanyl at all in older people because the Diprovan is so profound in its effects that you add the fentanyl to it, then you got cardiovascular collapse in your hands. So I'm not a real fan of narcotics in people over the age of 75 until I have them intubated and I know everything's okay. The incidence of thrombosis and phlebitis is usually less than 1%. And the good thing is if you do make a mistake and accidentally inject arterial injection of Diprovan, it doesn't seem to cause vascular compromise. It is going to cause a lot of pain. The person's not going to be happy with you and thinks you're an idiot. But the good thing is you didn't cause the hands to come off from necrosis. All right, the next drug, etomidate. Etomidate is a great drug to a certain extent, but it has one very severe limitation, and that's what limits it, okay, which is adrenal suppression. Okay? Otherwise, this is almost the ideal, perfect anesthetic. It comes as a liquid suspension. It can come in two vials. It comes in a vial where you can draw it, which is the way we used to do it. Or the way the ER gets it is this one, where they actually have it pre-filled syringe. The actual pre-filled syringe is 20 times more expensive than the vial. So we're getting the vials. Okay? The ER docs now have no more of these syringes right now in the country. They just ran out. Okay? And we don't know for how long, the manufacturer's telling us. So we're back to another shortage for the medication. Now, what contains etomidate, it's actually in liquid suspension because it is liquid soluble. It contains also propylene glycol in it, and it's a stabilizing agent. Okay? So what is etomidate? Etomidate is very unique, okay, in the sense that it's a carboxylated matazole-containing compound. The matazole ring, which is what I've got here in the box, okay, is very similar to midazolam, right? Midazolam has a matazole ring, so does etomidate, okay? And this is what gives us this water solubility, is a matazole ring. At acidic pH and lipid soluble at physiologic pH. So the compound that you're using to inject this is going to be slightly acidic. It's chemically unrelated to other anesthetic induction agents, but it is a little bit similar to midazolam in the sense of the matazole ring. The other one that has also a matazole ring, which I'll show you a little later on, is the dexetomidine. Okay? Dexmedetomidine is also has a midazole ring. The commercial preparations, an aqueous solution is unstable at physiologic pH, but as long as you have it in the acidic state, it stays nice and stable. So it's an acidic formulation. It usually contains a formulation of 0.2% solution, which means just multiply by 10, and that gives you the milligrams per milliliter. So it's 2 milligrams per cc is the actual normal formulation. The normal etomidate comes in a liquid state like this in the United States. You see how it's clear? Okay? And the 35% propylene glycol is what makes it acidic. They drop the pH down to 6.9, and that's what makes it painful when you inject, because you're giving an injection of acidic solution into the person, okay? And it causes venous irritation. The Europeans have figured out another way to take etomidate. This is not available in the United States yet, but it may be coming soon, okay? It basically has intralipid, so it's the same thing as Diprovan. Except, so now it's going to really make things confusing, because when you draw Diprovan, we used to not even label it because it was the only drug that was white. Well, guess what? You better start labeling your medications, which you're supposed to do anyways now, because if this emulsion comes in, it looks just like Diprovan, and it acts differently. The good thing is that when you use the emulsion like this, it doesn't cause any pain on injection, so it's a huge benefit to you. When you're looking at the etomidate, it's an enantiomer. It has the R shape. That's really the one that we use, so it's selectively pulled out. That's the only one that's really heavily more effective. There's new formulations of etomidate. They're coming down the pike, and these are kind of exciting, at least to me, because I'm an old-timer ICU doc, and I was putting people to sleep, but they were highly unstable, and Diprovan never worked for me, so I always used etomidate. But always in the back of my mind was a concern of adrenal suppression, and it still hasn't gone away. Am I still concerned about it? Yes, to this day, but I don't see sometimes a better choice because this agent is very, very cardiovascularly stable. So what do they do to try to change the formulation of etomidate? You can see the matazole here for etomidate. They added for MOC, which is methyl, I remember it in a minute, but it contains the MOC etomidate, has a carboxyl group at the end of it, carboxylic acid group, and what it does is it gives it more rapid metabolism to take place. So fast that it doesn't allow the inhibition of the adrenal to take place as much. So it gives you much better effect. Now, the other one that I think is better than that is what's called carboetomidine. Carboetomidine took the actual etomidate and just took off the nitrogen down here. So in the matazole ring now, you took off the nitrogen. And that alone will not allow it to bind to the adrenal. So this agent not has to be metabolized fast. It doesn't care. It just never binds to the adrenal. So it's a perfect agent now. Now it works just as well as etomidate supposedly, but without all the bad concerns of adrenal suppression. Now if that were the case, I would go back to using etomidate continuous infusions in neuro cases. We used to do it all the time for neuro anesthesia. Great agent, stable as heck, perfect for EEG studies where people were awake because it doesn't suppress the EEG activity. Okay, great for you doing MEPs and somatosensory evoked potentials because it doesn't inhibit them either. So really, in animals studies so far, it's been great. So now it's in preclinical trials in Europe. So maybe you'll hear it soon. It's going to be called C-etomidate or something. Who knows what it's going to be called when it comes to the United States. But if you see this, if you hear about it, it may be really worth the extra cost. The mock etomidate, also called methoxyl carbonyl etomidate, is rapid metabolism, okay, where it breaks apart at the end and it makes it inactive, okay, which is the mock etomidate carboxylic acid and also methanol, and that alone will make the molecule inactivate and not bind to the adrenal site anymore. Now, what etomidate does is basically, it's just like a GABA agonist. It is a GABA agonist, okay? It binds to GABA. It selectively binds to GABA alpha sites at the two sites, and it also enhances the effects of GABA that's already bound to it, so it is a potentiator, okay? It also has been found to bind to open chloride channels, which is a GABA is a chloride channel, so it binds and keeps the chloride channel open, so it potentiates the effect even that way. So it modulates the GABA receptor site by binding and to going and keeping the channel open. What's really impressive about etomidate is that therapeutic safety profile is very, very good. Okay? There's a huge difference between its hypnosis and its toxicity. Okay? And that's what makes this an ideal agent. Etomidate, pharmacokinetically wise, is 75% bound to albumin, so it's not as highly bound as some of the other agents. It does have a very large volume of distribution, as you'd expect, because it is a lipid-soluble agent and has a high affinity to fat. It distributes into body water and is favored by modest lipid solubility and its existence as a weak base. It penetrates the brain rapidly, reaching peak levels within 1 minute. So it's a little bit slower than Diprivan when you're doing an induction. And it takes about 10 or 15 more seconds before you see the effect. So when you give somebody Diprivan, you sort of get used to it. You can set your watch on it 30 to 35 seconds, the person's out. With etomidate, you're looking at 45 seconds to a minute before the person's out. And it sort of makes you like kind of antsy. Is it going to work? It works. So it just takes a little bit longer. The good thing about this is you also get very rapid awakening. If you see this is a single dose shot of etomidate. You come out of therapeutic range, usually between 5 to 8 minutes after you dose etomidate. So it's a great agent if you're doing a rapid sequence induction and you get into trouble. The person will wake back up on you, start breathing, and be now out of trouble just at the same time as the succinylcholine begins to wear off. So etomidate, Diprivan are both good combination drugs for rapid RSIs, except etomidate is better for the cardiovascular unstable patient. The context-sensitive half-time is ideal. Okay? If you look at Diprivan, which is propofol and etomidate is actually better. So you can actually give this as a continuous infusion, and that's why it was such an ideal agent in the ICU. That's why people loved it when it first came out. Unfortunately, it started killing people because of the adrenal suppression. It became such an issue that even though you have great context-sensitive half-time, you can't use the stuff because of the adrenal suppression killing the patients. But maybe if we get the carboxy or the carboetomidate, we'll be able to go back to using it again. The metabolism of etomidate is rapidly metabolized by hydrolysis. You see where it cleaves it? It basically adds an OH group and a hydrogen group to the other side, which makes it water soluble. At that point, it can't penetrate into the blood-brain barrier, and it becomes pharmacologically inactive. Then it's 85% excreted by the kidney. So 13% is actually gone, ridden by the bile, and 2% is unchanged and goes to the urine. What's responsible for this hydrolysis, of course, is the hepatic microsomal enzymes, and as well as the plasma esterases. Has etomidate been a problem with people with pseudocholinesterase deficiency? And there really hasn't been reported a problem with it unless you're using prolonged IV infusions, which you normally don't do. The clearance of etomidate is around 5 times that for thiopental, giving it a very short elimination half-life. We're looking at about 2 to 5 hours. One thing to be careful is etomidate give less in the elderly. You get reduced protein binding and reduced clearance in the elderly, so you get a higher effect. So instead of being the black line, the red line shifts, and you stay in a greater duration of effect. So if you gave the same dose, that person would stay asleep for 8 to 15 minutes instead of the normal 8 minutes. Etomidate is excellent in almost every way. It's a great amnestic. It's an excellent sedative. It can result in loss of airway reflexes, but most of the time the airway reflexes are not completely abolished. You would never use etomidate to put an LMA in. Never. It won't work. Okay? So it does inhibit the airway reflexes, and you have to always keep that in mind. You give that drug in high enough doses, you may lose the airway reflexes completely, and the person may aspirate. But it's not the drug of choice to put an LMA in. Propofol is the drug of choice for an LMA. Okay? It has no analgesic effects, so it doesn't blunt the response to laryngoscopy. So you can get a very hypertensive response to a patient when you're giving etomidate. So what can blunt that is you add opiates. Sometimes will help quite a bit. There's no muscle relaxation at all, but it will cause frequently myoclonus. It has minimal or no autonomic suppression, which is ideal if you have somebody who's cardiovascularly unstable. It produces less apnea than all the other induction agents, so the person will more promptly wake up, okay? And it causes no histamine release. When I used to use this drug in the ICU, it was great. Okay? The problem with it is if you wanted to do somebody with just etomidate alone without any muscle relaxant, which sometimes you had to do that because somebody had rhabdo or something like that, and succinylcholine was contraindicated. When you gave the etomidate, the myoclonus could be a problem. By that I mean that the person's mouth would shut down and it would get so stiff that you couldn't open it. Now, you can overcome it, but it's hard. And it just adds more difficulty to the intubation. The other thing you got to get used to if you're intubating with etomidate without anything else on board is that you'll have vocal cord movement as you're going in there. Okay? As you lift the airway, you'll see the vocal cords opening and closing as the person's breathing, and you throw it in. Safety profile is great, though, because the person's still breathing. So if you get into trouble, that person's just need to continue ventilating them. So the only thing is, of course, if you're doing an RSI, you want them to be intubated quickly because there might be a risk for aspiration. So you're giving etomidate followed immediately by succinylcholine and immediately by intubation, and keeping the cricoid pressure until you get the tube in. The clinical uses of etomidate is the IV induction, especially in the presence of unstable cardiovascular system. That's what it was made for. Okay, that's what it should be used for. My doses that I use for induction is I use 0.3 milligrams per kilo. The range is 0.2 to 0.4. I try to stay away from the higher doses because the higher doses can cause hemodynamic instability. Okay, because then you get into the toxic range. Remember I told you the toxic therapeutic range was a lot higher, but if you push it hard enough, you can get into trouble. I always tell you guys, don't draw it up in a 10 cc syringe. Draw it in a 20 cc syringe. Okay? If you have a 100 kilogram patient, you're going to give 30 milligrams. Okay? So, 30 divided by 2 is not going to, you're not talking about a small 10 cc's. You're going to exceed that. So make sure you draw it up in 20 cc's. Onset of unconsciousness occurrence within one arm to brain circulation. It lasts a good 5 to 10 minutes, and very often you see myoclonic movements. It can be partially attenuated by opiates. The other thing that we used to do quite a bit is that we would use it as a continuous infusion to maintain general anesthesia. And it's still used today in certain neurosurgical cases. Okay? The reason we do that is because we want to have perfect somatosensory evoked potentials and motor evoked potential monitoring, and it's an ideal agent to do. Unfortunately, the adrenal suppression issue has become such a big issue that people are a little bit afraid of doing that, and this has sort of gone away. But you'll read that in the literature about continuous etomidate infusion drips in the OR, and they do work, and they were actually pretty cool, but the problem is, again, adrenal suppression. Awakening after a single dose is very rapid, more than any barbiturate, and has very little hangover effect. Recovery is intermediate between methotrexate and thiopental, and the duration of effect is increased by increasing the dose and by continuous infusions. Okay? The principal limiting factor, again, is adrenal cortical function. Now, CNS effects on etomidate, if you're working in the ER, it's a good agent to use, and it's safe because it decreases cerebral metabolic rate of oxygen consumption, it decreases cerebral blood flow and decreases ICP, but maintains cerebral perfusion pressure. So this is kind of a good agent. As long as you're maintaining cerebral perfusion pressure, you're okay. So it's an ideal agent for head-injured patients. So if I have a choice, ketamine, etomidate, Versed, or propofol, I'm going to pick etomidate for a head-injured patient. That's my choice. Yes? I'll talk to you about that next. That's what we're going to get to. We're almost there. EEG effects is okay. Caution with people with focal seizures because it's not really there to suppress them. It's used to facilitate localization of seizure foci in patients with cortical reception. That's where we used to use it quite a bit when I was doing neuroanesthesia. We would give etomidate drips for patients that are having stimulation and define what the seizure activity was, because this drug doesn't suppress that. And one of the things that it's helpful for, if you run out of methotrexate, you can go to etomidate and use that. Again, the reason we don't use etomidate is because of adrenal suppression. You're worried about that in somebody even after a single dose, because ECT is going to require how many treatments? 8 to 12. Okay, so these people are repeat customers. So you're going to, every time you bring them back, you're going to hit them again with the stuff, and you're going to adrenal suppress them again, which increases the risk of dying from infections and develop aldosterone deficiency. Anyways, continuous-wise, the reason etomidate was so useful in neuroanesthesia is that it does give you a dose-dependent suppression of the brain, as the BIS indicates, and it correlates with sedation level. So etomidate, when used appropriately, can tell you, when the BIS will actually tell you the depth of anesthesia you're at. The good thing is that it doesn't affect the monitoring capability as much as the other agents. You do still get an increased latency and decreased amplitude with auditory evoked potentials, but the actual somatosensory evoked potentials have increases in enhanced amplitudes. So that's a good thing. That means you're able to watch somebody more closely, and your motor evoked potentials suppress less than any other agent that's out there. So it makes it really an ideal neurosurgical anesthetic. Etomidate cardiovascular effects is also ideal. The induction dose of less than 0.3 milligrams per kilo. You get that's why I use this dose. Has minimal changes in preload. It does decrease afterload just a little bit because you get a 15% fall in SVR. If you're severely hypovolemic, it may drop your pressure a little bit, but it's not like any of the other agents because it doesn't affect the preload. So this is one of the few that doesn't affect preload. All the other ones affect preload, okay, except for ketamine as well. So contractility has minimal changes and minimal changes in stroke volume, cardiac output. Heart rate has really no change. When you put a laryngoscope in them, the heart rate can take off on you because that's sympathetic stimulation and doesn't inhibit the laryngeal response, but that's a different problem. But the actual drug itself, when given to somebody without stimulus, doesn't really affect the heart that much. If you go up on your doses and you're not careful, you get into the toxicity range at the 0.45 milligrams per kilo dose. You can get into the hypotensive range because you start causing now preload changes as well. So I'd be very cautious on that higher end. Stay away from that. Cardiac has minimal effects on myocardial activity, okay, and is safe in patients with cardiomyopathies. Renal-wise, it doesn't really decrease renal blood flow, so there's no real associated renal toxicity with etomidate. Again, all these are great things so far, right? Ventilatory depressant effects seems to be less with barbiturates. Okay, apnea is occasionally after rapid IV, but that takes a lot. It causes a decrease in tidal volume and increase in frequency of breathing, so it's a little bit different than the other agents. because the rate, actual respiratory rate goes up. You'll see little puffy breaths. They just start, they breathe, and it's a little bit more difficult to intubate them at times because the vocal cords start moving more fast. You just got to catch it in between, throw it when the cords are wide open. Or you turn the tube 90 degrees and split the cords, and it opens them up. That's another technique, too. The effects on breathing is transient, and it only lasts 3 to 5 minutes. So that comes back pretty quick. Etomidate does cause pain on injection because of the acidic milieu. Okay? You're looking at pain of up to 80%. Decrease in pain on injection is I give lidocaine ahead of time, or you can, if you think you're safe to give opiates, you give a little bit of opiate ahead of time. I'm not a real fan of that because in case the reason you're using etomidate is because you have cardiovascular instability, and I don't want to suppress the sympathetic nervous system at that point. Usually it's helping me keep the person's pressure, so I'm not a real fan of that. Okay? It does not result in detrimental effects accidentally into the artery, which is good too, so you do mess up, and it actually will still work. It will recirculate and get to the brain and have the effect. It is metabolized extensively by the liver, so you can expect it to be shut off pretty quick, but at least something will take place. Myoclonus is a problem. It causes an excitatory effect that gives you spontaneous movements, dystonia, and tremor, and people really kind of freak out. You want to see the circulating nerves kind of think, they're used to seeing Diprovan, and they sort of go to sleep, kind of like they go out, and the etomidate will get rigid, and look kind of like, what the heck's going on? It looks like a seizure. And that's not seizure, it's myoclonus. It's you're causing a disinhibition, and the flexors take over, not the flexors, but the flexors go out, and the extensors get activated. So that's what gives you that myoclonic movement. Okay? The way you can decrease that is split dose inductions, which means you split half the dose. You can precede it with opiates, or you precede it with benzodiazepines. There's a little higher incidence of, it seems like hiccups occur with etomidate, similar to barbiturates as well. So it's a higher incidence than Diprovan, because you don't never see that. You can see hiccups on Diprovan, but usually it's because you're putting the LMA in too early, and you induce the hiccup response. Okay? That's usually not the direct effect of the drug. It's because you manipulated the airway too early and cause that effect. Postoperative nausea, vomiting has been an issue. Anecdotally, the initial reports is that people that got etomidate had a 40% incidence of PONV. What unfortunately, when they started doing anecdotal reports like that, nobody really follows up with it. So there's really few studies comparing to other induction agents. And our endo centers, when we use etomidate, we sometimes use etomidate mixed with Diprovan, we see almost no change in nausea vomiting rates, and these people are going home, especially for people who are cardiovascular unstable. I'm not a real fan of mixing Diprovan and etomidate together, but the guys that do it have said, well, it gives you the antiemetic properties of propofol and sort of reverses the effects of etomidate, which is okay, but if I give them straight etomidate, I don't get nausea vomiting that much, so I don't know. It depends on the procedure that you're doing. If you're doing colonoscopies and endos, you're not causing pain. At least during the procedure you are, but afterwards you're done with the pain, so I don't know. I think it's sometimes associated with pain. The new lipid emulsions had the same nausea rate but slightly increased rate of emesis as propofol. So it kind of made it a little safer, supposedly. Then they actually have a good randomized study of that as part of the study that they were doing right now as a preclinical trial. Now here's what etomidate does that's bad. Etomidate basically is an adrenal suppressor. Okay? It causes adrenal suppression by producing a dose-dependent inhibition of conversion of cholesterol to aldosterone. So what you see is this is a normal breakdown that's taking place on the adrenal cortex. Cholesterol is being broken down and eventually produces cortisol as an end byproduct, and the other one is aldosterone. There's two places where etomidate binds to. It binds to 7-alpha hydroxylase, but the most important place that it binds to is 11-beta hydroxylase, which is a P450 enzyme, and it suppresses it. So when you do that, you get accumulation of 11-deoxycortisol and 11-deoxycorticosterone. Okay? Both those will indicate, if you draw assays, that you've got no more production of cortisol. So cortisol drops off dramatically, which is a stress hormone, and the other thing that drops off dramatically is aldosterone. So as a consequence, you get a adrenal crisis in your hands. Okay? As the adrenal cortical suppression takes place, what you should see is the body will respond by increasing ACTH levels to try to kick up the cortisol levels. But can you increase the cortisol levels? The answer is no, because you've inhibited the enzyme. Okay? So even though you've got increasing levels of ACTH, the actual suppression is at the adrenal cortex and can't happen. The adrenal suppression duration after a single IV dose is as long as 6 to 8 hours. So it's actually not a good thing. Okay? If you give a continuous dose and you stop it, it can last up to 24 hours, which is even more concerning. Etomidate should be used in caution or avoided in patients that require an intact cortisol response, such as sepsis, or patients that are hemorrhagic patients, which is why you're doing it a lot of times, and may result in what's called a stress-free surgery, where you need these cortisol and aldosterone levels to help you. It does not get reversed by giving that person ACTH, obviously. And the effects on clinical outcomes have never been studied in a large population. They do know that the mortality rate goes up in the ICU if you give continuous infusions of this stuff. A lot of people still argue that etomidate is a better agent than everything else that we have, so maybe it's worth the adrenal suppression that we see for 6 to 8 hours. And nobody's been able to prove that a single dose of etomidate increases mortality and morbidity. Nobody's done that yet. So until they do that, I think this drug is not going to go away. It's going to keep being used. I hope that before that happens, if somebody proves that it's really a bad idea, they come out with carboxyetomidate, and we'll have that instead, and maybe we'll be able to use this agent safely without any major concerns. The symptoms of adrenal insufficiency is kind of weird. The patient will come to the recovery room and tell you that I feel weak, I don't feel strong. That's the biggest complaint that they have. You think initially the person has residual neuromuscular relaxation on board, and they don't. Okay. You also will see pigmentation changes in the skin if it's prolonged. Weight loss, again, also that's prolonged. Sometimes people complain of abdominal pain. They'll also get salt cravings, diarrhea, constipation, syncope, and vitiligo. Treatment is maintain the airway, make sure the person's breathing okay. What I would immediately make sure that you don't, if the person's unconscious, that you check for all the other reasons why somebody's comatose. Are they hypoglycemic? Okay, and give them, naloxone if you think that the person is on overdoses of narcotics. And at that point, if you see hypoglycemia, you still got to think adrenal crisis, okay? Because that's one of the things you see very often. Hypoglycemia is very common with inadequate levels of cortisol. So what you need to do is you need to revolume, resuscitate that individual. But the way we do it, if you give D5 normal saline, and if your sugar levels still stay low despite that, you need to give D50, okay, to make sure that that person gets their sugar back up. And you want to be above 90 if you can, so as soon as you can. So the things that you got to correct aggressively is hypoglycemia. Hyponatremia is very common because you don't have aldosterone, right? So no aldosterone, no free sodium uptake, so the person begins to waste salt. Hyperkalemia is very common, but when you resuscitate them with fluids, that usually goes away, as well as hypercalcemia. And the other thing that you need is to give them Solu-Cortef. That can be life-saving for this individual if they have adrenal crisis. Solu-Cortef is hydrocortisone, which is given 100 milligrams IV. You can give it every 6 hours. And usually you give 2 doses of it and you're done, because by that point the etomidate's worn away, and then the person's endogenous cortisone begins to be reproduced. If you're on that long-term etomidate dosing, you would need to be getting fludrocortisone, which is the aldosterone equivalent. Okay. All right, we'll start the next thing on ketamine. Ketamine is a good agent in certain ways, and it's also one of those agents that can be really problematic. It's actually abused quite often. It's becoming a big problem now in the community. It's called Special K by the people that are abusing it. They can snort it, inhale it, or inject it. Okay? I don't really understand why the heck anybody would do this to themselves, but it gives you a state of complete dissociation. You don't even know you're there. You don't even know you're human. So I don't really understand the drive to do this drug. Okay, but it's also been used as a date rape drug, and they're making it a lot more difficult to get this drug because of it. Where most of these medications were being obtained to do that kind of stuff was from the veterinary offices, and they were taking veterinary ketamine and putting it in people's drinks. So just make sure that you always keep your drink covered. We just never know when somebody will drop something into your drink. The other drug that was being used a lot for that was Rohypnol, and Rohypnol, they actually had to change the medication and put a dye in it. So when you would put it in somebody's drink, it would immediately turn the drink blue. But of course, the criminals got around it once again. The legal one that's available in the United States has that dye, but the stuff that they can buy on the street to do this stuff with doesn't have the dye in it, which is just never ceases to amaze me. So ketamine is something that we use a lot. You got to be very careful about the concentrations. Okay, this is 500 milligrams per 10 cc's. Okay, so that's a 50 milligram per cc dosing. Ketamine is a PCP derivative. I'll show you a picture of what PCP looks like in a minute. It gives you a dissociative anesthetic, and the person will basically go into a cataleptic state. That person will look at you and will not track you, will not know you're there, will not hear you. It will move, and you can actually put them in positions, and they stay there. It's really a strange drug. Okay, the patient becomes non-communicative and may actually appear awake, and which is a little bit worrisome at times. And sometimes you'll hear sounds coming out of them that's very animalistic, but it doesn't mean anything. They don't remember any of it. So it is very a strange drug. Okay, it does cause very intense amnesia, and also gives you very intense analgesia as well. Ketamine comes in several concentrations. The one that we use IV mostly is a 10 milligram per cc dose. If you were giving it to a kid to knock them down, you can give it IM, and you can give the 50 milligrams, but we tend to go more towards 100 milligram per milliliter dose because it gives you less volume, and you'll be able to inject it more rapidly into the kid with less of a problem. But you got to be aware of that because, gosh, if you pull up the 100 milligram vial and you give it IV because you think that it's going to be, 10 cc's is what you should give, and now you're given 1,000 milligrams, that person's going to stay asleep for a few days. So make sure you be careful which one you're drawing up for that day. So these are the 3 vials. They look very similar, don't they? Just a little bit different color. So ketamine is one of those things. I don't like it myself. I've used it, but I'm very, very restrictive of it. Some people use it like water. The worrisome that I have is when people start using it as water, is I always consider that they're taking it home with them. Okay, and that's what concerns me. This stuff is addicting for some reason, and just keep that stuff under tight control. You don't want it leaving your department because there is criminal activity that surrounds ketamine use. Ketamine structurally is a water-soluble molecule. You can see the top molecule above it is actual PCP, which is the original drug that was thought to be that was going to be useful. Okay, PCP has too many side effects, including extreme violence, hyperexcitation. People will actually go absolutely insane, and they feel absolutely no pain with PCP. It's a drug that you cannot understand. I've seen people break away from restraints, 4-point restraints, leather, that are 1.5 to 3 inches thick, and they break through it like it was nothing. And this is a normal person. So they have no sensation of pain. And this guy actually flipped the gurney up and decided to start destroying our emergency room. So it was a rather interesting day. So those kind of things that you have to worry about. Now, ketamine is a little bit cleaner in the sense that it doesn't seem to have as much of that kind of hyperexcitation, but it does have very similar things to PCP, which has intense analgesia. It has a little bit more rapid metabolism and more rapid recovery, and there's a lot lower incidence of emergence reactions with ketamine than with PCP. The danger of PCP is that when people do it, they get flashbacks. They could get it a year later, 4 years later, 10 years later. Okay? LSD is even more dangerous. LSD is like a derivative close to a family of it. And LSD is very, very dangerous, to say the least. When they're making this stuff, they have drug houses that build this stuff. They're actually they're almost like chemical labs. And they've had several instances where the actual people breaking into these areas have then got dusted with LSD with high contaminated values, and they really got into trouble. One of the actual agents died, and the other one was permanently neurologically impaired. So this stuff is out in the street. Ketamine is not as toxic as that in the sense that it does give you flashbacks, and for that reason, I would never give it to a pilot. If a pilot if somebody finds out that the pilot had received ketamine, they'll rescind his license. Okay, so you can't give that to somebody who is going to be in the transportation business. Okay, so it's not really appropriate to be using it. If you work in the Air Force, you don't want to give ketamine to your fighter pilots. It's going to ground their ass real quick. Okay, so both isomers exhibit catecholamine uptake by postganglionic sympathetic nerve endings, which has a cocaine-like effect. What ketamine is very unique is that it interacts to many different receptors. So it's not just a GABA. It's actually not a GABA agonist at all. Okay, ketamine binds to NMDA receptors. It also binds to opiate receptors. It also binds to monoaminergic receptors, muscarinic receptors, and calcium channels. The biggest effect is on NMDA. Okay, that's its biggest effect. It's a potent analgesic at sub-anesthetic doses and may actually be mediated by a slightly different mechanism. It actually binds to the opiate receptor, but it's not binding at the same site as its opiate receptors, and it's an agonist-like activity. So it's just like an endorphin. So it suppresses pain. And ketamine does not interact with GABA receptors. The NMDA receptor is a member of the glutamate receptor family. Glutamate is a primary neurotransmitter in your brain to keep you awake, okay? And it acts basically as a non-competitive antagonist of this receptor. So it reverses the effects of glutamate and then suppresses you. It basically dissociates your cortex from your midbrain. So you're still awake in your own head. You're basically you're like inside of a container where you have no light, no auditory stimulus coming in, and your brain just thinks about the last thing. It keeps going over the same thought. So people that do ketamine, what they do is they usually have a picture in front of them or something they want to dream about, and then they get themselves a ketamine, and that's what they start dreaming about repetitively. And it gives them a very intense hallucinogenic experience. The problem with it, of course, is that if you think something bad right before you go hit the ketamine, you're going to get to meet the devil, or you're going to get to see somebody you really don't want to meet, okay? And it can be life-altering. I had one guy that came in, he was really not a very nice guy, and we were about to, he was in shock, he'd been multiple gunshot wounds, and he told us that he hated us, and that he wanted to meet the devil. And right at the same time, we gave him ketamine. Well, he got to meet the devil. See, that's what he told us. And after that, he became a priest. And he actually became a very good person after that. So it is a life-altering experience for him. So these drugs are very, very potent. They're not to be joked with, not to be played with. But you always got to think about the first thing. Put a good thought to the person's brain before you put them down. Okay, if you can. If you can't do that, then add benzos ahead of time to sort of affect, not have that kind of bad effect. Okay. What basically this medication does is it interacts with PCP, phenylcyclidine binding receptor site, leading to inhibition of the NMDA activity. Okay. The other place it binds to is opiate receptors. It interacts with both mu, delta, kappa, but also binds to sigma receptors. Sigma receptors are not considered, remember we talked about, are not really opiate receptors, but that's what gives it that dissociation kind of effect. But it is a very intense analgesic for this reason alone. And you can give subtherapeutic doses where you don't get the hypnotic effects, which it doesn't bind into the NMDA receptors as much, but given to the opiate receptors, it gives you a fairly decent analgesia. And it definitely works in a different mechanism than the opiates, because when you have opiates and nothing's working, when you give that person ketamine, it does work for some reason. So there must be a different binding site or a slightly different interaction at the opiate receptor. Some people actually think, and I haven't proven yet, think that it upregulates opiate receptors. Okay? And that's how it actually acts. So if you're giving it to somebody who's on chronic opiate therapy and has been downregulated, if you give them ketamine, it upregulates the opiate receptors, and now you get an effect that you want, which is kind of cool. Okay? I think it's a good idea sometimes at the end when you have somebody who's been on oxycodone forever, and they're telling you that they're using it like M&Ms at home, that I give ketamine at the end of the case to help me more smoothly transition so they're not screaming in pain in recovery. Ketamine also binds to muscarinic receptor sites. It's partially antagonized by anticholinergic agents, so if you give somebody atropine, it reverses the actions of ketamine. It does produce anticholinergic symptoms like emergence delirium, bronchodilation, and sympathomimetic effects that you expect. And it basically acts as an antagonist to muscarinic receptors, so it inhibits acetylcholine binding, and so it causes tachycardia and increases heart rate. The pharmacokinetics of ketamine. Pharmacokinetics resemble thiopental. The rapid onset of action, relatively short duration, again, it's due to redistribution and high lipid solubility. The PK, 7.5 physiologic pH, so that's 50-50. The peak plasma concentration occurs within 1 minute after IV induction, and if you give it IM, it's within 5 minutes. So that's pretty fast. I mean, if you dart somebody, they're going to be down pretty quick. Not highly protein bound and redistributes from brain to less well-perfused tissues, and that's what terminates its action most of the time until it gets eliminated. It does have a high hepatic extraction rate, about 1 liter per minute, a large volume distribution, which is around 3 liters, and very lipid soluble. The high extraction rate suggests alterations in hepatic blood flow may actually affect clearance. That's an important consideration. The metabolism is extensive. Most of the time it's broken down by the microsomal enzymes, which is the P450, into what's called norketamine. So it's a process that makes the molecule less potent, but it's still a residual molecule in the sense that it has some effect. It's about 1/5 to 1/3 as potent as ketamine, and that may be the reason why it has prolonged effects sometimes. If you mix it with halothane and diazepams, you may actually slow the metabolism down of this drug and get a prolonged effect as well. And tolerance with ketamine can occur with more than 2 short interval exposures to ketamine. So one of the things that people that are doing vitamin K out there is that they keep having to up and up and up the dose to get the same effect. I saw one guy that was actually doing 300 milligrams at a time, and he was doing it every 25 minutes. It's pretty crazy. Okay, so that's a pretty heavy dose. Clinical uses is unique induction agent due to the fact that it's a sub-anesthetic doses make it cause intense analgesia. And it's basically very useful for burn patients, and that's where we use it a lot. Induction of anesthesia is prompt when you give it higher doses, and what I would recommend is you give an anti-sialog with it, because the person will literally drown in his own spit, which is one of the bad things about ketamine. What people do I won't tell you what they do. This is crazy, but they eventually what causes a lot of coughing, laryngospasm due to salivary secretions. What we prefer to do is we use glycopyrrolate as anti-sialog, okay? Because glycopyrrolate doesn't cross the blood-brain barrier. It's not like the tertiary amine like scopolamine or atropine, which they actually increase the emergence in delirium, so I would avoid those agents. Ketamine, the induction dose is usually about 0.4 milligrams per kilo. It's what I usually use, IV, which really produces a very intense analgesia. The plasma concentration of ketamine that produces the analgesia is lower after oral or IM administration, of course. The analgesia is thought to be greater for somatic than visceral pain, which is, I think that's it's very hard to tell which one is better, to tell you the truth. But that's what some people's impressions are. I personally can't tell the difference. Analgesia can be produced during labor without associated depression of the neonate. Yeah, that's fine, but they found out the hard way where I used to work at in Chicago. They decided that they were going to give somebody a ketamine drip that they couldn't put an epidural in. What they forgot is that, yes, it is effective at taking away analgesia. It's a very good analgesic, but it doesn't protect your airway. And this poor woman aspirated and died. So you should not be using IV ketamine drips on somebody with a full stomach. You have to have it in people that are appropriately managed, and women that are pregnant, of course, are full stomachs. The other place where it's used, which I think I will never use, is putting it in the epidural and endothecal space, because it doesn't really give you that much enhanced analgesia that's worth it. You have too many side effects with it, too much sedation. So, and most people will say it's very limited in its use, and it's definitely not as potent as opiates are, giving it in the epidural or endothecal space. Doses of induction is 1 to 2 milligrams per kilo. Is the normal consciousness is lost in 30 to 60 seconds. If you're looking at if you give the 4 to 8 milligrams per IM doses, consciousness is lost in 2 to 4 minutes after the single IM dose, which is pretty impressive. If I'm doing kids, I stay on the lower end. I just want the kid to be stunned, somebody I can manage, not to be apneic, okay? Which is sometimes if you give the 8 milligram dose, the kid stops breathing. So stay on the lower end. Return to consciousness takes 10 to 20 minutes. That's more than enough time to take him back to the room and put the mask on him and get him off to sleep. It actually may take them almost an hour for them to be really fully reoriented. And emergence times are greater after repeated doses or continuous infusions, which is sometimes not done very often, but if you are going to do it, it does cause problems with emergence being slower. It's useful, when you use it, it's very useful in hypovolemic patients, as long as you have an intact sympathetic drive. If you take somebody with a sympathetic drive that's wiped, the myocardial depressant effects of the drug will show up. So it is a direct myocardial depressant. So if you don't have endogenous catecholamine stores or the sympathetic nervous system is impaired, you can get into trouble with this drug. So if you give high doses of opiates with this drug, you can get in trouble with this drug. Okay? Sometimes it's been used for coronary artery disease patients with diazepam and ketamine together. The danger of ketamine is that it increases cardiac myocardial workload because of sympathetic discharge and may actually increase oxygen consumption rates. And that's why they added the diazepam to it ahead of time, so you get a slight depression of that effect and you don't get as much myocardial effects as a consequence. Ketamine induction is more stable hemodynamically, especially subanesthetic doses with propofol for TIVA, and when you combine TIVA with propofol and fentanyl. So in that case, it gives you analgesia and good amnesia and you combine it with the propofol. Some people I've seen, they take the ketamine and just put it into the propofol and they combine it. I don't like doing that. I always do my drugs separately. So I would do I do a ketamine drip with Diprovan separate, but other people, they like the dilutional effects. The only thing I don't like about it is that nobody's really reported what happens when you give ketamine in a scientific study when you put ketamine into propofol. So you don't know if you're causing the emulsion to become unstable. So for that, I'm not a fan about putting anything in another drug. The only drug where I ever do that will be Robenal and neostigmine from safety reasons. But otherwise, I don't do it in any other drug. Avoiding patients with systemic hypertension and pulmonary hypertension, as those may get worse and increases ICP. This is one of the limitations of ketamine. You cannot give it to somebody with central nervous system effects. In eye surgery also may not be a good idea because you get a lot of lateral nystagmus with this drug. so the surgeon can't operate. The patient's eye is constantly moving, and you can't get it to stop. It's a stimulant to the cardiovascular system through the sympathetics, but actually it's a myocardial depressant. It may cause emergence delirium. This is what you see. The kid's looking at you, but he ain't there. Hello? Anybody out there? Nope. Okay? And when they start waking up, they start going crazy. If you want to see nurses not be happy with you, give ketamine every day. The nurses will truly hate you. They will find a way to make sure that they get even with you. And that's how I always find out who the new doc in town is that's giving a lot of ketamine. Because the nurses come and talk to me and says, "Doc, this is another doc with ketamine problems." I'm like, yep. And they use it a lot in residency, but they don't realize that we were taking care of 80-year-olds here. You don't give ketamine to 80-year-olds. It's not a good thing. Okay? They don't wake up. They had one case where the patient went to the ICU for a week before he woke up. Okay, so ketamine, and they didn't overdose it. They gave a normal dose. But the problem is that it doesn't get metabolized well in the elderly. And the other thing is it may increase ICP, placing patients with intracranial pathology at risk, so that's where you don't want to give this drug. Cardiovascular effects is it resembles sympathetic nervous system stimulation, so you get an increase in systemic arterial pressure. PA pressures go up, cardiac output goes up, and myocardial oxygen requirements tend to go up. Benzodiazepines or inhalational agents may sometimes blunt this effect, but occasionally critical ill respond by decreases in blood pressure and cardiac output because it is a myocardial depressant. So that's for that reason I'm a little cautious with ketamine. A lot of people, they always remember that ketamine is great for cardiovascular, but they forget that it's a myocardial depressant. And when the person's been sick in the ICU for a long period of time on epinephrine doses, and that's what's supporting them, well, they downregulate. When you give them ketamine, you get the myocardial depressant effects, and you get none of the sympathetic effects. And then it can fall apart on you. If you look at the graph that comes in the book, it shows you what normal ketamine will do. Heart rate goes up significantly by 33%. Well, that's going to increase your myocardial workload. Your mean arterial pressure goes up, which increases your afterload, which increases your isovolumetric contraction time. So what does that do again? It increases your myocardial workload. So somebody who's marginal, you can get myocardial depression and ischemia with this agent. But what you don't see too much changes in stroke stroke volume index. Your SVRs really not really change that much, and your right atrial pressures don't really change much. It does increase a little bit, but not significantly. And your left ventricular end diastolic pressure doesn't really change. Your PA occlusion pressure, though, does increase. Most of that is going to be due to not so much volume changes, but rather due to an increases in SVR, which is then is going to increase your back pressure inside and cause POP to go up. Your minute work index does go up by as much as 40%, and that's a considerable amount, and that may induce ischemia and cause problems over time. Ketamine is a direct stimulant of sympathetic nervous system outflow, and as a consequence may enhance the dysrhythmogenic ability of epinephrine when you're injecting it into a patient. In vitro, that's where they came up with the direct myocardial depressant effects. When you take a frog's heart, put it inside of a bath, and start letting it beat, and you give ketamine into the bath, the heart slows down and stops. So it's pretty potent. Okay? Ketamine's effect on ventilation, it doesn't produce enough significant depression of ventilation as much. If you give it enough, it will cause apnea. The upper airway skeletal tone is well maintained, but it's not enough to protect your airway. And the biggest problem is that you begin to drown in your own spit. And I mean, it literally starts pouring out of you. It is a great bronchodilator. So it's another indication for using ketamine. Somebody who's in status asthmaticus, ketamine is a good agent. Okay? And that's where they usually ask you in the test question on the boards. They'll ask you, which patient is the ideal one to use as an induction agent for somebody who's in severe status asthmaticus? And the answer tends to be ketamine. Okay? Ketamine has no effects on the liver, no effects on the kidney. It doesn't really cause histamine release and doesn't cause allergic reactions. So it's a pretty safe drug in that area. It does interact with drugs in a bad way because it's acting at the NMDA receptors. If you use it with halothane, it can result in severe hypotension because halothane prevents the sympathetic nervous system from working. So you unmask the direct myocardial depressant effects of ketamine. And the other thing that ketamine will do is it decreases the MAC equivalent to halothane. So you've got to drop your halothane as well. And I think most of all anesthetics, you've got to drop down when you give ketamine. If you give diazepam and midazolam, it's also effective in preventing the cardiac stimulating effects of ketamine. So when you're giving them, we usually will pre-treat these people so they don't get the emergent delirium. I personally use midazolam because it's more effective. Verapamil, when you add it to ketamine, you get the attenuation of the blood pressure elevations, and the actual heart rate, though, it does increase dramatically, and that's a little bit concerning. Volatile anesthetics prolong the duration of action of ketamine. They also, the duration of apnea after succinylcholine is prolonged by ketamine. We think it's because it inhibits the cholinesterase activity and prevents the breakdown of succinylcholine properly. It also enhances the action of non-depolarizing agents, and the Pavilon that you add to it sometimes will cause a significant tachydysrhythmia. So it's not the ideal agent to use in somebody who's already going a fast heart rate. And some seizures have been reported in asthmatic patients receiving ketamine and theophylline together. Theophylline is a nasty drug. I never use it intraoperatively. The mortality rate with theophylline goes up in the operating room. So for that reason, I always shut off my theophylline before I take them back to the operating room. I'm not a believer. There's been several reported cases of people dying intraoperatively for unknown reasons when you have theophylline drips going. So for that reason, I don't use it. Now, emergence delirium is a real problem. Emergence from ketamine can be associated with visual, auditory, proprioceptive, confusion illusions, and may progress to delirium. And it depends on what they were thinking before they went to sleep. Some of the hallucinations are pleasant and they come out of it okay. Other times they become out violent and they're fighting the nurses, and then you get called back and you're having to sit on the top of the patient so they still. It's not something that's happy. I'm not a fan of ketamine, let's put it that way. Incidence ranges from 5 to 30%. I think it's higher than that myself. And factors that increase incidence is ages greater than 15 years of age. Women tend to have a much more problem with this drug. In doses of greater than 2 milligrams per kilogram can cause more of a problem. And there's also an increased history of personality disorders or frequent dreaming increases the delusional states. It's psychologically in children it's no different than compared to inhalational agents. That's what they say. There's no significant long-term personality differences are present in adults or children that receive ketamine. And if you repeat the doses, you get less and less emergence delirium. It seems like the brain begins to accept this drug more. Inhaled anesthetics can also produce auditory, visual, confusional illusions, but the incidence is more common after anesthesia that includes ketamine. Benzodiazepines are effective at preventing this. Midazolam is more effective than diazepam. That's why I tend to use it. I usually will give midazolam 5 to 10 minutes. And I give it in pre-op before I give the ketamine in the operating room. Inclusion of thiopental or inhalational agents may actually decrease the incidence of emergent delirium with ketamine. But again, depends. The one thing that you want to avoid is atropine or droperidol, because they actually increase the incidence of delirium when you add it to this agent. The last agent to talk about, yay, we're almost there. Dexmedetomidine, okay, also known as Precedex. Because of this word that I can't ever say, I use Precedex. Sorry, so I'm going to use Precedex. On your certification exams and on my exam, I'll put down the real name, which is dexmedetomidine, but it's just a pain to say, so I just use Precedex. Okay. Precedex is a centrally acting postsynaptic, but it's also got some presynaptic alpha-2 adrenergic agonist activity. So it acts just like clonidine. Clonidine is a sedative. Now, what makes this uniquely different is the affinity to the receptor is 1,600 times to 3,600 times higher with Precedex than with clonidine. So it's much, much, much more potent. Okay. Precedex has in it, just like etomidate and Versed and the imidazole group. The imidazole compound gives it water solubility. Okay? What we use it for is two things, either as an adjunct for anesthesia, or I'm sorry, that should have been shifted over one, ICU sedation. Those are the two major reasons for the use of dexmedetomidine. Now, if you've never used this drug is really different. Okay? When you give it to somebody in the ICU, you load it with 1 mic per kilogram IV loading over 10 minutes. And then you do what's called a sedation evaluation, and then you put them on a continuous drip of anywhere between 0.2 to 0.7 mics per kilogram per hour. Okay? If you're doing it for less invasive procedures such as ophthalmic surgery, you drop it down, your induction dose, to 0.5 mics per kilo. And if you're doing a wake fiber optic, you can do the same thing. It works well. You can do a loading dose of 1 mic per kilogram over 10 minutes, and that gives you enough sedation to be able to do the procedure without too much of a problem. And for patients over the age of 65, a loading dose of 0.5 should be used in those people. Now, I wish I had Precedex when I had to intubate somebody with an allergic reaction the other day in the ER, but we had to do it awake on this individual because they were almost to the point that they were closing their larynx. Anyways, the properties of dexmedetomidine, or Precedex, is that it's a sympatholytic. Okay, it's a great sedative hypnotic. It has analgesic properties, so it reduces but does not eliminate opiate utilization, and it has minimal respiratory effects. What really makes this drug very strange is that the person, when you walk into the ICU, the person will appear asleep. Okay, and you'll talk to them, and the person will look at you just like me and you are looking at you, and will talk to you, and then as soon as you walk out, they close their eyes back down and they're asleep. And if you ask them their ICU stay, even though they're talking to you, well, they're not really talking because a lot of times they're intubated, but they're still able to write things down, communicate with you like they're awake. So you really believe that the person's not sedated. And that's what's really freaky about it. Okay? But when you actually ask them after they're out of the ICU, do you remember anything? And they don't remember anything. So they're not able to form memory. So they almost suspend them. You keep them in a state where they appear to be awake, but they're not. Okay? Now, do you want to do that in the operating room? Heck no. So we drive them to a much deeper level. Okay? Which, of course, when you drive them to the deeper level, you're going to get a lot of the side effects, which is what the limiting factor of this drug is. There's too many side effects. The mechanism of action is that it's an alpha-2 agonist. So it's going to bind to the alpha-2 agonistic. And it, like I said here, is 1,600 to 3,600 times the affinity to receptor in comparison to clonidine. So it's going to have a very potent effect. It doesn't really affect the alpha-1 receptor at all. It only binds to the alpha-2 receptor. It has a very large volume distribution. It has a mean elimination half-life that's actually fairly short, 1.5 to 3 hours. And if you give it transdermally, which you can, it's a little bit prolonged at that point, which is 5.6 hours. It has a very high protein binding, which is about 94% of it's bound to albumin or alpha-glycoprotein, which that's the limitation again. Because if something is so protein bound, if you decrease protein content, what's going to happen to the potency of that drug? It's going to go sky high. Okay, see, you guys are learning. Good. Okay. Metabolize extensively in the liver, and it produces methyl and glucuronide conjugates, which then make them water soluble, and then can be renally excreted. This is the actual comparison. I took this off the website for Precedex. It shows you that the potency on it is fairly good. And just look it over, just to give you a general idea of comparison to the other drugs. It's just more for general information purposes. The precautions that you got to use with this patient is that you got to be very careful with patients that are hypovolemic or hypotensive, because the alpha-2 effects will cause vasodilation, because it inhibits the release of norepinephrine. It's also got to be careful on patients that are elderly. People that have advanced heart blocks or severe ventricular dysfunction can have problems when you give this drug to them. And if they have diabetes or chronic hypertension, it may also be a problem. And watch doses for patients that have hepatic impairment or renal impairment as well. These are the adverse effects that you get with this drug. That's quite a bit. That's a long list. Okay? The most common problem being hypotension, and you get also a weird reaction, which is hypertension. The hypertension is when you take the person off this medication. It's like taking them off clonidine. Okay? That's when you get trouble with. So sometimes you You take this person off, and you almost appear like you almost have a malignant hypertension syndrome on your hands, okay, which is a little concerning. If you use it for the operating room, you don't see that effect. It's too short. But in the ICU, where you have prolonged effects, you get norepinephrine vacuoles that begin to accumulate in the nerve ending, then you can get into trouble. Okay? Nausea is a high rate, it's 11%. That's higher than the narcotic rate, so that's a concern. So there's a lot of different little complication rates, so it's quite a bit. And that's it. That's all, folks, for today. Okay? I got done right on time.